All right, good morning. This is Jay Patel again, PGY8 fellow at VCU, and today I have Dr. Hashmi, one of the cardiac surgeons at VCU, and we'll be talking about mitral regurgitation. So, Dr. Hashmi, you're asked to see a 45-year-old female with a past medical history of hypertension, tobacco use, diabetes, who's been referred to your clinic for management of severe mitral regurgitation that was found during an echo that was performed for working up her shortness of breath and new palpitations. So, how would you go about evaluating and working up this patient?
So I'm reviewing the echocardiogram, assessing to see if it's primary or secondary MR, to look for any MAC around the mitral annulus, and to assess if there's any other valvular abnormalities. On the mitral valve, you said there was severe regurgitation, so I'm going to try to classify this in the Carpentier classification, with 1 having normal leaflet excursion, 2 having excessive motion and prolapse, and then 3 is divided into A and B with restricted motion versus restricted motion in both systole and diastole versus just in systole. As far as the severe mitral goes, you want to confirm that it is by looking at the parameters on echocardiogram, measuring the vena contracta, the volume, the regurgitant fraction, and looking at the orifice area, and also assessing for any other valvular pathology, looking for tricuspid aortic insufficiency, tricuspid regurg, to see if any of those need to be addressed as well.
Okay. And Dr. Hashmi, remind me, what are the cutoffs for those echocardiographic findings that define severe MR?
So the vena contracta, anything greater than 7 millimeters, the volume, anything greater than 60 milliliters, the regurgitant fraction greater than 50%, and the effective orifice area greater than 0.4.
Okay, excellent. So say you review the echo and you confirm severe mitral regurgitation, which appears to be from P2 prolapse with an anteriorly directed jet. Additionally, you find that there's moderate tricuspid regurgitation with an angular diameter of 45 millimeters. There's no aortic insufficiency. How would you proceed with the workup?
The workup's going to include left heart cath to rule out any concomitant coronary artery disease if that needs to be addressed. The atrial fibrillation to assess for that, the left atrial size, getting some labs, checking their hemoglobin A1C, fructosamine, since they have had a history of diabetes.
Okay. So say the hemoglobin A1C is 6.8%, and you do get an EKG in the clinic, and that confirms that she's in atrial fibrillation. She denies any history or even knowing that she had atrial fibrillation. The left heart cath was negative for coronary artery disease. So knowing this information, what would you offer this patient?
Well, a 45-year-old person, I would offer them a repair over replacement. The echocardiogram showed an isolated P2 prolapse, so my go-to would be to try to repair this valve first with a concomitant maze and left atrial appendage ligation.
Okay, excellent. And now remind me, who would you offer surveillance to with mitral regurgitation? What are your operative indications, basically?
So anyone with severe MR is going to get addressed surgically. Anything less than that, and being asymptomatic, you could do surveillance. But if someone has severe MR, has a lower EF, has LV dilation and diastolic dilation, I would pursue surgery as their option.
Okay, great. And she asked you a couple of questions, whether you're planning to choose a mechanical or a bioprosthetic valve, and whether or not she would be a candidate for a MitraClip. What would you say?
So my initial approach is to do the mitral repair. If we're unsuccessful, then replacement would be the option. Given her age, mechanical valve would be preferred due to its longevity, addressing the need for lifelong anticoagulation with Coumadin, and it having teratogenic effects, so counseling for pregnancies. Um, Otherwise, as far as MitraClip would be anyone that is not a surgical candidate, so any severe comorbidities, but given the patient that you've described, surgical approach would be her option.
Okay, and her last question is whether or not you would consider doing a minimally invasive mitral valve repair through a thoracotomy. She asked if she would be a candidate for that.
Yeah, so our approach is minimally invasive unless there's any indication where peripheral cannulation might be of an issue, if we're doing any other concomitant operation aside from the maze or appendage. So if I was having to replace any of the other valves or address the coronary artery disease, then I'd go with the sternotomy approach. But otherwise, if her BMI is not that high, access through the right chest doesn't seem to be an issue, I would offer her minimally invasive.
Okay, great. So, Dr. Hashmi, why don't you walk us through your steps of undergoing a sternotomy mitral valve repair versus replacement, kind of your cannulation strategy and your operative pearls there.
So cannulation and cardioprotection are of utmost importance, giving you the best exposure. So aortic and bicaval cannulation, antegrade and retrograde for cardioplasia, cardioprotection. And then the mitral valve exposure, there's a couple different ways. Preferred option would be through Sondergaard's groove through the left atrium, developing the groove, rolling off the right atrium. Other approaches would be the transeptal approach through the right atrium, and then also going up to the left atrial dome through the transeptal approach, which you need to be aware of possibly injuring the SA nodal artery.
Now that you have the mitral valve exposed, how would you go about repairing this?
So two different approaches to repairing the mitral valve. You could do your triangular or quadrangular resection with a sliding plasty. The other approach is just putting neocords. Neocords, there are companies that offer pre-made neocords. You could also make your own neocords with the Gore-Tex cords. You could pre-make them before actually even going on bypass by measuring from your papillary muscle head to the coaptation line. Another approach is to actually put in the neocords and then measure intraoperatively, assessing the coaptation of the anterior and posterior leaflets. So my personal approach is just to do the neocords, although either one has shown to be equally as effective.
Okay, so say you adequately repair the valve and you do your test and there's not much leaking from the valve. You did a triangular resection and you're weaning off of bypass and the anesthesiologist tells you that there's now a significant amount of SAM and there's also moderate mitral regurgitation. Can you go through kind of what SAM is and what are the things that increase your risk for SAM? And what would you do now that you know you have moderate mitral regurgitation after your repair?
Yeah, so SAM essentially is where your posterior leaflet was probably not pulled down far enough. So your anterior and posterior leaflet, when they kind of come together, there's still residual leaflet of your anterior leaflet that gets pulled into your LVOT. And it's abutting the septum with each contraction and affecting the LVOT outflow. So the treatment, number one, to prevent that is to be able to pull your posterior leaflet height down far enough so the coaptation line between your anterior and posterior leaflet is more towards the posterior annulus. So if you have SAM as you're trying to wean off bypass, the first thing to do is to volume load the LV to kind of help open up the LV cavity. So the overall goal is to open up the LV cavity to help prevent SAM. You could do decreasing of your inotropes, decreasing your heart rate by using beta blocker, and increasing your afterload. So these maneuvers will kind of help prevent SAM or decrease SAM. But with after all that, and you still do have moderate MR, you have to go back to the underlying cause and go back on bypass and fix this. Is the underlying cause either you didn't pull your posterior leaflet down far enough, or is it that you made your annuloplasty ring size a little too tight? So you don't want to make that too small.
Okay, so say you go back on bypass and you just decide to go ahead and replace the valve. What are your pointers and steps in replacing this mitral valve?
Yeah, so if we're going to replace the mitral valve, you've taken your annuloplasty ring out, you're looking at the valve, you want to preserve your posterior leaflet, you want to preserve, as much of the subvalvular apparatus. So you take out, you transect your anterior leaflet. What I personally do is once I remove it, leaving a little rim around the annulus, but move the anterior leaflet, and then I transect that down the middle, so I have two halves of the anterior leaflet. And I'll take one half, the lateral side, put it around the 3 o'clock position. The lateral one, put it around the 7, 8 o'clock position, and the one on the right, put that around the 3 or 4 o'clock position. And so you're taking those bites with your annular sutures, your pledget sutures, where the pledget's sitting on the atrium side. And the key in putting these sutures are being aware of where your coronary sinus is and where your circumflex artery are, right? The LVOT is somewhere between your 9 o'clock and 12 o'clock position, so you want to move that leaflet not there. That's why we move it to around the 7 or 8 o'clock position when we're taking those bites to leave our LVOT open. The coronary sinus is around your 4 to 6 o'clock range, and your circumflex artery is around your 8 to 10 o'clock range. So when you're taking these bites, you got to make sure that these bites are going from the atrium into the ventricle and then back up into the atrium, right? If you feel your bites are more tangential into the annulus, that's when you're going to hit either the sinus or the circumflex. And what, as we've done with you guys, whenever we explant recipient hearts for heart transplants, I think that's a great time just to go to the back table and look at that mitral valve annulus, and take some scissors and just cut, and you could see how far or close the annulus is to either the circumflex or the circumflex artery, to kind of give you an idea. So then as you're putting these bites in during mitral replacements, you have a gauge, an understanding of where the surrounding structures are. Oh, and then the other thing is around the 12 o'clock position, being aware that that's too deep. You're getting into your non-coronary cusp of the aortic valve.
Okay. And so lastly, say you're coming off of bypass, you did your mitral valve replacement, and now there is what appears to be moderate to severe aortic insufficiency as well. Your concern is that you ended up getting the non-coronary leaflet. What do you do now?
Yeah, at this point, having to go back, I would leave the mitral the way it is, go back and just address the aortic valve.
Okay.
You'd probably end up just having to replace the aortic valve.
Okay, makes sense. All right, Dr. Hashmi, well, thank you so much for all that. That was a really useful review of mitral regurgitation.
Thank you.